This video illustrates individual practice quality improvement in outpatient psychiatry. It works through an example of improving the timeliness of documentation to promote safe transitions in care. You are a community-based outpatient psychiatrist. In the past week, you've received 3 voicemails from family physicians and 2 voicemails from patients stating that they have been waiting over a month to receive your consultation reports. My family doctor didn't receive your consultation report, and I saw you over a month ago. I haven't been able to start treatment yet. You decide to do an individual practice quality improvement project to clarify why it's taking you longer than usual to send your consultation reports. You want to implement a change in your practice to improve the timeliness of your documentation as you're concerned about the impact on patient safety. You vaguely recall an email bulletin about Health Quality Ontario, part of Ontario Health. You go to the Health Quality Ontario website and you find the following summary of the Model for Improvement, the Approach to Quality Improvement, which was developed by the Institute for Healthcare Improvement in the United States. You notice there are 3 key questions to answer, and these correspond to establishing an aim, creating a measurement plan, and identifying a change to improve the healthcare process. Some additional questions are listed to help you structure your improvement plan. Once you have answered these questions, you can proceed to test out your change using a plan, do, study, act quality improvement cycle. To begin establishing your project aim, you start with some background work as recommended by the Model for Improvement. You decide to review the College of Physicians and Surgeons of Ontario policy document on transitions in care, as you recall that some standards have been set about how quickly you need to get your consultations back to the referral source. You see that the policy document indicates consultants are expected to distribute non-urgent consultation reports within 30 days of the consultation. You find a reference to the Health Quality Ontario Project Charter on the HQO website, and you decide to adapt it to improve your individual practice. As such, you can ignore some of the fields on the form as these apply to team-based QI projects in other settings. You use the QI Charter tool to begin defining your problem. As you are writing your problem statement, you find yourself wondering how often your consultation reports take longer than 30 days to reach their referral source. Based on the recent voicemails you received, you estimate perhaps 30% of your consultation notes are sent out after 30 days or more. You decide to look back in your booking calendar to find your last 10 consultations, and then you review the charts for these 10 patients to see when you saw the patient and when your consultation report was sent out. You record the information in a table. You are surprised to see that 70% of your reports are sent out more than 30 days after the consultation. You decide to use a quality improvement tool called a process map to figure out why it is taking you more than a month to send your consultation reports. You review each of the steps you take to prepare consultation notes. After seeing the patient, you quickly jot down your impression and plan and file these with the notes you took during the assessment. You then finish clinic. After clinic, or sometimes a few days later, you find some time to dictate your consultation report. Once you finish dictating, you send the recording to your administrative support, who transcribes it and sends it back to you as a Word document. Then, when you have some time, you review the document and make any necessary corrections or clarifications. You send the file back to your administrative assistant for final formatting. Once you receive that file, you print it, sign it, and give the hard copy report to your administrative support to be faxed and mailed. Wow! You are surprised by how many steps there are in the process. You notice a few places where the process really slows down, and you identify them as pain points. Now that you have a clearer understanding of the process you use to complete your consultation reports, you resume working on the next section of the project charter to plan how to improve the process. The project aim statement is a sentence that summarizes what you are trying to achieve. An effective aim statement meets all of the criteria of a SMART goal, meaning it is specific, measurable, attainable, realistic, and time-bound. You compose the following aim statement for your project. By October 1st, I will send 90% of my consultation reports to referring healthcare providers within 30 days. You confirm that your aim statement meets all the criteria of a SMART goal. Next, you begin to develop your measurement plan. According to the model for improvement, measures are needed to tell you whether the changes you are making are actually leading to tangible improvement. They give you concrete evidence to support your case for change. Outcome measures tell you whether you are achieving your aim or hitting your target. Process measures provide indicators of key steps in the healthcare process to achieve the desired result. You review your process map to help you to identify potential process measures. You decide to measure the date on which you edit each consultation report. Balancing measures look at the healthcare process from other perspectives. For example, patient satisfaction, healthcare provider satisfaction, or financial costs. Balancing measures can also measure unintended ripple effects of the changes you are making within other aspects of care. In your practice, you are concerned that you will simply add more work hours to your week to achieve your goal of improved timeliness. You are aware that working more hours will not be sustainable in the long run. So, you decide to measure how many days per week you are arriving home after 6 p.m. Having completed your measurement plan, you begin thinking about how you could change your practice to reduce the time to complete your consultation reports. Fortunately, there are a variety of quality improvement tools that can help you to generate change ideas, which are ideas to improve the process of care. A check or tally sheet is a simple tool which can help you to identify the underlying factors contributing to a problem. This tool involves tallying how often the different causes of a problem are occurring. In your practice, you identify 3 main reasons for the delayed completion of your consultation reports during the month of May. In 2 instances, you were waiting for collateral records. In another, your administrative support was on vacation. And in 4 instances, you were delayed in completing the dictation. Another tool used to generate change ideas is the Ishikawa Diagram, also known as a Fishbone Diagram. This tool helps identify different contributing factors to the quality problem. You begin to brainstorm and then categorize the factors that contribute to the delay in your consultation notes to populate your Fishbone Diagram. Based on your tally sheet and your Fishbone Diagram, you decide to implement the change idea of scheduling 15 minutes at the end of every consultation to dictate the note. To test out your change idea, you implement a plan, do, study, act cycle, or PDSA. For the next 4 weeks, you will schedule 15 minutes at the end of your new assessments with the goal of completing the dictation in that time. You measure the number of days from the date of consultation to the date the report is sent to the referring physician, which is your outcome measure. You also measure the date you are dictating the note and which date you edit the note, which are your process measures. And you create a check sheet on how often you are arriving home after 6 p.m. to capture data for your balancing measure. You decide to plot your outcome measure on a graph called a run chart, a quality improvement tool that helps to visualize and assess if changes are leading to improvement. You set up your run chart with the date of consultation on the x-axis and the number of days to complete and send the consultation report on the y-axis. You plot your data sequentially, week by week, and annotate when you introduced your change. You are glad to see that in June you completed and sent 60% of your notes within 30 days. However, you are a bit confused because you successfully dictated most of the notes on the day of the consultation, and so you thought you would be doing better than 60%. You look more closely at your process measures and see that although you dictated all of your notes within 30 days, you were delayed in editing 4 of the notes. Your balancing measure check sheet indicates that you arrived home after 6 p.m. on 3 of the 22 workdays. You're relieved that, for the most part, your change idea did not lead you to work longer hours. You're both encouraged and a bit discouraged by the results from your first PDSA. You remember reading somewhere that quality improvement does not stop after one PDSA cycle. Although you have made some headway, there are opportunities to test out additional change ideas through iterative PDSA cycles. You decide to maintain the change of scheduling 15 minutes at the end of every consultation to dictate the note. In addition, for the next 4 weeks, you decide to schedule 30 minutes every Friday to edit the dictations from the previous week. At the end of the month, you are pleasantly surprised to see on your run chart that your second change idea worked. You're also relieved that with both changes, you still haven't been arriving home after 6 p.m. more frequently. You decide to continue to schedule time in your calendar for dictating and editing to sustain the improvement and make it stick. Your run charts clearly show that the changes have been effective, and you decide to maintain these changes to your practice going forward. Disseminating practices that have the potential to improve quality of care elsewhere is a crucial final step of a quality improvement project. You decide to share your change ideas in your peer supervision group and on related chats about practice management on social media. When you complete a personal practice improvement project, you are not only improving patient care, but also accruing continuing professional development credits. For example, you can claim Section 2 or 3 credits with the Royal College of Physicians and Surgeons of Canada. The College of Physicians and Surgeons of Ontario Learning Management System has some additional learning modules on quality improvement. The system is available to those who are participating in the CPSO Quality Improvement Program, and a subset of participants will also be offered coaching in quality improvement.